Hello and welcome to the Talking Precision Medicine podcast. In this series, we sit down with experts on the application of AI and big data analytics in the drug discovery space. Our guests are innovators, business decision makers, and thought leaders at the intersection of data and therapeutics. We discuss the promise, practice, challenges, and myths of AI in precision medicine. This show is brought to you by Genialis, and Rafael, its CEO, is your host. Genialis is focused on data integration and predictive modeling of disease biology to help accelerate the discovery and de-risk the development of novel therapeutics. Today, Rafael is joined by Dr. Sarma Velamuri, founder and CEO of Luminare. Luminare is a Houston-based digital health company dedicated to ending sepsis, the #1 cause of death in U.S. hospitals. In the conversation that follows, Dr. Velamuri explains how Luminare saves lives by streamlining hospital workflows and by changing the behavior of nurses and doctors. They've also made a giant leap into COVID tracking, emerging as national leaders on this front. Let's get right to it.
Welcome everyone to Talking Precision Medicine. Today our guest is Dr. Sarma Velamuri. Sarma and I have sort of known each other for over 5 years now, both growing our companies in the Houston startup ecosystem. And passing in the hallways around various incubators in the Texas Medical Center and so forth. Sarma is co-founder and CEO of Luminare, which is a truly visionary, in my opinion, health tech company. But I'm going to let Sarma tell us about it. So Sarma, welcome. First of all, thanks for joining us. And tell us, what is Luminare? What are you trying to do?
Thank you, Rafael. A good question. In order to tell you about Luminare, I have to give you a little bit of background about myself. I'm not a typical company founder. I like to say I'm a recovering physician. My day job was working in a hospital taking care of patients. By qualification, I'm plain old internal medicine, but I work only seeing patients in hospitals. So that's called a hospitalist. And just so happened that 80% of my patients were transplant. So they were either heart, lung, liver. I've had a few intestine transplant patients and prosthetic hearts and things like that. These patients end up dying of sepsis, which is the body's response to an infection. And Luminare, which is Latin for to shed light upon, is a company that does software-based robotic process automation for hospitals to detect sepsis faster and stop people from dying of sepsis.
So I think most of our listeners will have heard of sepsis. And there's kind of this lore that, especially if you're an older person, staying in a hospital is more dangerous maybe than going home. But how big a problem is sepsis? Is this a real issue that we have to contend with?
Good question. If you asked me that question 5 years ago, I would have had a different answer. Even as a doctor, when I started the company to quote unquote fix sepsis, I wasn't quite aware of how big a problem it was. Sepsis is the #1 cause of death in US hospitals. It's the #1 cause of maternal fetal death globally. It's the #1 cause of chronic organ failure that is preventable. #1 expense in inpatient stays in the hospital. #1 cause of readmissions to the hospital. I mean, the list goes on and on and on. We're spending about $15 billion a year on sepsis annually. And apart from the financial cost, conservative estimate, there's about 800 people a day who die in US hospitals today, every day. And that's like 2 Boeing 747s falling out of the sky every day in the US. And it's been that way for years. And that's how big the problem is. It's 250,000 people a year in the US that die of sepsis.
That sounds absolutely tragic. And why is sepsis such a killer? Why do people fall prey to it? Why is it hard to treat or diagnose? Is it detection that's the issue?
Good question. So sepsis is very heterogeneous. So, when people think of diseases like heart attacks or they think of strokes, they have some subtle variations within them, but largely there's the same problem. Either the person's bleeding out into their brain or there's a blockage going to their brain. Either the person, heart is not pumping like it should because of some electrical problems, or there's a blockage of blood going to the heart, right? So that might manifest as different things. The problem with sepsis is people say sepsis and they think infection. It's a very heterogeneous, we call it like a shape-shifting disease. It's not just an infection, it's more of the body's response to an infection. And the response is abnormal. And so what I mean by that is, think about a bull in the arena, right? So you have a guy who's standing there in a fancy dress, like with a big hat, and he has a sharp stick, right? So he pokes the bull with his sharp stick, and the response, the bull is huge. This guy is tiny, and the stick is really, really small. It's like a nail.
Right.
It's pretty cruel, but the point is the response this thing has, the animal has to the inciting event is just completely out of proportion. It goes nuts and starts wreaking havoc. So that's what your immune system sometimes does with sepsis, is the response is completely out of proportion sometimes to the infection, and that response ends up killing the person. Because it's wreaking havoc and chaos in the body, it looks different in different people. And so sepsis is kind of like an old word that we're using for a group of syndromes that masquerade as a single object, so to speak.
So I actually have two questions now, and I think I know the answers to them just because I know a bit of your history. But one is, why did you choose, as a hospitalist, why did you choose sepsis as the problem to solve? What was the kind of spark moment? And then the other is, what is the solution you've come up with? So if it's such an oddball disease, right, or maybe it's a class of diseases hiding under one IC number, right? Like it's got a single code, but a lot of different stuff going on. How do you tackle that?
Yeah, you've kind of lit a fuse now. So, I was pretty happy with my job as a hospitalist. I really enjoyed it. I saw a lot of rare diseases. My job was to figure out, a lot of situations, patients would end up on our service that nobody else knew what was wrong with them, and they would be transferred to our hospital, and, super interesting. And sepsis was more of an annoyance to me. As a young physician, I was afraid of losing patients and that, my patients would die. Of sepsis is the thing that kills people in hospitals. And so I would start my day looking at my list thinking, I have 25 patients on my list. How do I make sure none of these patients die before lunch today? And so invariably sepsis was the answer. So I would look for sepsis in every patient. And, when you start looking for things, you start seeing things. And so I started seeing these common denominators to sepsis. And to me, it was more of an annoyance, really. Like, it's like I'm trying to get my patient home and trying to make sure they have an uncomplicated stay. And the workflow in the hospital was broken. So I ended up in several situations where I would walk into the room. There would be an experienced nurse looking after a patient. And this patient is clearly headed towards septic shock. And I would be like, hey, let's call the nurse Joe. I would say, Joe, like, hey man, how come you didn't call me? Like, our patient's headed south for the winter. And you'd say, what are you talking about? I say, he's going to be in septic shock in 6 hours or 8 hours. And you'd be like, what? And I'm like, yeah, look in the computer, man, is white counted through, and the guy said, I haven't had time to see the patient yet, like in the computer, because I'm busy taking care of the patient, right? So that was one problem I had consistently, is I'd walk into the room, even experienced
the information's hidden in plain sight.
Yeah, exactly. And so if you're not looking, you don't see it. And so for me, it was more of an annoyance. So I ended up joining the hospital's committee one day because I spent literally 6 hours trying to get the patient care, because it was obvious to me they were septic. Everybody agreed, and I'm waiting on pharmacy. I'm waiting for bed control. I'm waiting for the janitor to clean the ICU room. I'm waiting for the right person to bring the medication up from the bowels of the hospital where they store the medications. And I got frustrated just standing. I started yelling. I don't yell very often. And so I realized that, maybe I can fix the problem from the inside. So I joined the hospital's committee for sepsis. So I started looking on this path. While I was doing all this, I realized we need more efficient software. And in the meantime, my friends, I'm on this committee, my friend's daughter ends up in the hospital. And I share this story very frequently. You probably heard this one before, but I went up there just to pay a social visit to see his kid on hospital day 3. I get off the elevator, they call code blue. And my friend is standing outside, he's crying. And I'm just, inside, I'm thinking, oh man, this thing is, real. I go in to the room, my intern, resident, a whole bunch of the code blue team is there. They're doing chest compressions on this kid that I was, sitting at bedside, talking to her, cracking jokes the night before. And they get tired, so I start doing chest compressions, and then eventually, 45 minutes pass, and I realize that can't do anything about the situation anymore. And she passed away, and I had to go tell my friend his daughter died, and he fell on the floor. And mom had gone home for a short period of time, take a break. When mom came back, I had to have the same conversation again, and I went home, and it was the worst day of my life. And something inside me broke. And in my naivety, I decided I would not be a part of a system where this could happen. And it wasn't anyone's fault. That's the thing that I kind of point out. The nurses and doctors, like everybody who took care of her, they took care of her to the best of their ability. Everything was done exactly right, and she still died. We should be able to predict this. Software should be able to predict this. This is not rocket science. And the software didn't exist. And so I decided that I would try and build it myself. My wife said no. So she said, no, you're not going to code school. Remember that patio you built? It took you 3 months and cost 4 times more than it would have if someone else built it for us. So so I ended up mortgaging the house and starting a company in the garage with Marcus Rydberg, who you've met, who's from Sweden.
So you guys have a true garage startup. It's like Steve Jobs and Steve Wozniak up there.
Yeah, that's right. And because of COVID, we've moved 10 feet away. I'm now in my bedroom attached to the garage.
Yeah. So all right. So you software was the solution. Tell us a bit about Luminare software and what does it take in? What does it put out?
Yeah. Okay. So we just got our patent. So, it came in the mail. So it was lying on my table. So I've been holding it up on the Zoom calls.
Oh, congratulations.
Just for fun. Thank you. So it took 5 years. So it was pretty exciting. Yeah. So,
not even defensible in the EU, probably. It's,
I don't care. So what I used to say in the early days, which I don't say anymore, is, if you think you could solve this problem, build something that does what we do, knock yourself out. And because, we're a mission-oriented company, anyone that's able to stop people dying in hospitals, I will help them. The problem is you pretty much have to build Luminare in order to replicate what we're doing. You've got to have the same sort of... the software, it's really a process, right? So imagine the Coca-Cola bottling company back in the 1950s, right? You have a conveyor belt, you have Coke bottles or, passing on this conveyor belt. And let's say something broke somewhere, or, some sprocket broke, some belt broke somewhere. It used to be that there's a guy in an overall who shambles over to see where it's broken. He examines it, takes clipboard, fills out the part requisition, walks it back, and then goes to the warehouse, gets the part, gets the guy to fix it, and end of the day your operating line's out for 8 hours, right? So that's where healthcare is right now. That's how we operate. It's you have a person who physically goes and examines the person, then says, oh, okay, this is broken, and then they go reach out to another person. And we have software, great, but the software is not a workflow software. What it does is it's very good at what it does, which is it's a repository for information, but doesn't actually enable you to do anything with that information. Yeah, there's some passive alerts built in, but not really. Okay, so fast forward to Coca-Cola bottling plant 2020. Something breaks. There's a software program, usually it's SAP, I think they have SAP. It basically looks in real time, says this part is broken, here's the requisition number, automatically tells the guy to send it down. There's a robot that picks up the thing and brings it down. Your downtime is less than 5 minutes, right? And so what we built was essentially a workflow tool that uses software that, think of it as a checklist that auto-fills itself. If there's not enough information, it asks the nurse for questions like, hey, does this person look sick to you? Is this person breathing fast? And adds information, makes the information more accurate, tells them what to do next. If it doesn't get done, it tells your boss. If your boss doesn't pay attention, it'll tell their boss. If their boss doesn't pay attention, it generates a phone call, right? So it's in the business of making workflow happen. So we go to a hospital, we get them to agree on workflow, and then the software makes sure that the workflow actually takes place.
Gotcha. So it enforces a workflow, but it also automates that workflow, and it intervenes if the workflow is not
That is
being met.
correct. That is correct. And so the reason AI sniffers, right, is the buzzword in the industry right now is
Right.
people think that building a more sophisticated alarm works.
Mm-hmm.
All that building a more sophisticated alarm does is creates an alarm that gets ignored because the nurse is at bedside taking care of the patient, and you have this young doctor walking into the room saying, "Hey, why didn't you call me? The alarm went off. What are you doing about it?" And the nurse goes, "I didn't see the alarm. Why didn't you see the alarm? Well, I'm taking care of the patient."
Yeah. I can also say from experience, when I've had to spend an overnight in hospitals, either for myself or with my kid or something, I'm going around the room trying to shut off as many of the alarms that are beeping constantly as possible so I can get some sleep.
Yeah,
so
exactly.
having something that beeps when there's really a problem is probably preferable.
Yeah, and it gets ignored, by the way, today.
So I'm interested, to the extent that that patent allows you to talk about it. What are some of the kinds of data that your software, which it's called Sagitta, is that right?
That's right, Sagitta. Yep.
Sagitta. What are some of the kinds of data that are captured? And does that depend on, like, hospital to hospital what their workflow is, or do you have like a standard checklist that this comes equipped with?
Good question. So we were in the Center for Disease Control's interoperability showcase for HIMSS. To exactly answer this question, we were being used as an example of how we tie different data systems together. So we take information from the EHR system, we take information from the monitors, we take information from the labs. We even have a site right now that uses the patient's insurance information to create a higher accuracy on what's going on the floor with the patient. So we take information, anything that's digital and that's present in the EHR or anywhere, we take that, and then we add a clinical judgment layer to that information. So we have a system that allows you to interact and judge, clinically, is this information accurate? Does this person really have fever? Are they really having a fast heart rate in real time? And so anything that lives in the electronic medical record, we use.
Gotcha.
The future also holds the number of times a physician or a nurse or someone opened a chart is actually a good indicator of how sick that person is. Just FYI.
No, that actually makes a lot of intuitive sense, but probably not something you'd think it's too simple almost, right? It's too perfect.
Yep.
The insurance information doesn't actually surprise me either. I mean, Epic, after all, was bill collection software once upon a time. Like, follow the money, and that's really fascinating. And I love software as a solution to speeding something up that is both manual and error prone because of how manual it is. How do you, I want to come back to the software and what it does, but how do you feel about, or what's your experience been building a business where you have to sell something to hospitals? I mean, you're in Houston. So for those of you who aren't in Houston, a buddy of mine described Houston as like Vegas for hospitals, right? Like.
That's right. That is correct. I don't think our company would exist if we were in any other city but Houston, to be honest with you. I think a part of the reason the solution, good ideas are usually born simultaneously in many places at the same time. And that's, seen over and over again with inventions and, pretty much any scientific discovery. I think, we're uniquely positioned because Houston is like the Texas Medical Center, world's largest medical city. We have 18 member institutions, over 100,000 healthcare workers in like 10 square miles. And, we got to see the sepsis problem in, 10, 15 different settings within the same city. I was able to essentially walk into any hospital, request for time with their nurses, nursing leaders, the CIOs, the CEOs, CFOs, sit down, talk to them, and really examine the problem from all angles before we built anything. So it's been enormous to have this resource with us.
Yeah, no, I mean, the Texas Medical Center offers a product discovery experience like none other if you're solving problems for hospitals, probably.
Yep.
And what is the value proposition you lead with? Is it the humanist, you will have fewer deaths in your hospital, or will lower your expenses, or lower readmission rates so you get that value-based care bonus from payers? Like, what resonates? Yeah. Here are the three pillars of what we do. Boom, boom, boom.
Yeah. So it's funny you should say that. I'm not going to name names, but I actually had a CFO once tell me that, what's so compelling about your solution is, I get 100 pitches a day about like the human side of like some software that's being sold or hardware that's being sold. We have this interesting situation where every time a hospital deploys our product, we're actually able to produce a measurable financial change that is attributed to us. We're able to produce a measurable change to, their fill in the blank metric that either a doctor is looking at, a nurse is looking at, or a CFO is looking at. And so we lead with a different thing depending on what we're saying. Right. And very interestingly, the CFOs are the ones who actually care about the clinical outcomes. I would think that they care about the financial outcome, but it turns out that a lot of our CFOs have been like, they're like, yeah, we get all that cash stuff, man, but like the fact that this is going to help our patients, like, is really, CFOs become our executive champions within hospitals. And the doctors are going, this is, I got the clinical side of this, great, but as long as it makes financial sense, I could take it to the CFO because I'm sick of taking stuff to them that gets shot down because, it's good for the patient, but not good for the hospital.
Well, that's fantastic. It sounds like you walk into a sales meeting and the person you're trying to sell to is already thinking, how do I sell this within my organization? So
exactly. Yeah. So we don't sell as much as we show them the product. We kind of, sales for us is more about just qualification, like making sure that we are actually useful to the hospital and then providing people internally with, the ammo to go and kill it. So sorry you about must be crying in the background.
Hey man, we're all working from home these days. As long as it's not your sales rep doing the demo on the other line who's doing the crying.
No, he's happy now. Yeah.
So I'm curious to the extent you're comfortable talking about it. How far and wide is Sagista deployed now? How many hospitals are you in? Like, are you outside of Houston by now? Or are you in other locations?
Yeah, so we're in a couple of states now. We have a few chains of hospitals that have contracted. We haven't particularly grown as aggressively as we would want to because we're making sure that our scale model doesn't break. So we haven't really turned the key on full commercialization just yet. We're deploying, making sure that we figure customer success out. We make sure that we don't really get support tickets. The software itself has been used over 100,000 times to date.
Oh wow!
On real patients by nurses, and it's more about process, right? It's figuring out what are the processes within the hospital. How do we engage with the physicians? How do we display metrics back? And we got pretty good at it. Like I said, we were excited to be able to work with the CDC. They were using our company as a showcase member for their sepsis showcase, saying, hey, they don't endorse private companies, but we were in their showcase as a CDC partner to teach hospitals how to do it.
Fantastic. No, that's really interesting. Are you able to back of the envelope estimate that? I mean, roughly how many patients have used this. Do you see savings of life? Like, are you able to boast it?
Yeah. We have a counter that in real time looks at how many interventions we have. We have crossed 100,000 users on the platform, and we're estimating about 200 lives saved to date. And that's a very conservative number. We say that we've decreased mortality like 98%. We don't make mortality claims. We make claims that we'll implement workflow because we're not a class 2 medical device. Right. But we haven't actually seen a patient develop septic shock and die on our platform in the last 2 years.
That's amazing.
And and it's not an attribution problem. Sometimes some people die and they say, well, it's because they had something else, not sepsis, right? We know it's not an attribution problem because as a side effect of deploying our software, hospitals have been telling us, hey, just FYI, all-cause mortality went down. So all-cause mortality went down 12%. So people stopped dying from other things too. Less intubations, less rapid responses, less ICU lengths of stay across the board. Doctors are, telling us that, hey, when a nurse calls us, we tell them to preface the conversation with, hey, we're calling you because Sagitta told us to call you, because they take those calls more seriously than, oh, I'm calling you because I have heebie-jeebies on my patient.
Yeah.
Which is the opposite of a plain old alert, right? Because most of the alarms that go off, the nurse is like, the alarm went off, and the doctor goes, yeah, thanks, and hangs up.
Interesting. So I have two more lines of questioning, and we can do them in whichever order you want. You mentioned class 2 medical devices, so I'm interested in the regulatory burdens and hurdles you face. Everything from data privacy and security and deployment to regulatory agencies. And then let's do that one first. And I also want to talk about your product roadmap and sort of how you think about data and interventions and what you can learn sort of from that feedback loop.
Mm-hmm. So, like I said, we're not a class 2 medical device. We don't make mortality claims to a hospital. We just kind of report our pilot data, and they can talk to our customers themselves and see what their mortality is. So eventually the plan is we will be a class 2 medical device. We're just, we just don't see how that plays into our business model right now, because we are, my passion and mission is making sure the patient gets care. And in sepsis, you have 60 minutes from the time that the person starts showing signs of sepsis to treat. For every 60 minutes after that you wait, mortality goes up by 6%. Or nowadays, we've seen long-term mortality go up 10%. Let me translate that 10% number. If a person goes to a hospital, gets their chest cut open, has cardiac bypass, sewn back up, goes through 2 weeks of therapy, of physical therapy, goes back home, they have less than a 0.8% chance of dying. So less than 1 in 100 people who have their chest cut open in their late 60s with diabetes, hypertension, heart disease dies from open heart surgery, okay? With sepsis, young people in their 20s, 30s have a 10% chance of dying every hour. It's 10 times worse per hour to get sepsis than to have
open heart surgery.
Than open heart surgery. Okay,
wow.
So here's the thing. It's all about workflow, right? So if I can get treatment to the patient within 60 minutes, right, that mortality stays really, really low. And that's what we do. So we are a workflow optimization system more than an alarm medical device system. And because all of these alarms that you have in place are useless till you can guarantee that the patient gets treatment. So that's the step we take. It's like most hospitals have inaccurate alarms, so we had to build that in order to go to hospitals. But we don't sell mortality benefits. We sell workflow. So regulatory perspective, we've gone through the FDA's Q-Sub process. We fall under the discretion enforcement pathway, which is a lot of verbiage to say we're not a class 2 medical device and we don't make mortality claims to hospitals.
Gotcha.
And we make that very clear to a hospital. It's like, hey, they ask us what is your mortality difference? We say, well, no, you can ask our customers. They implement our software and their mortality goes down by 90%. But that's not us. That's just their workflow gets better. So, just so happens they use our software.
Gotcha. That makes sense.
We take this very seriously, especially after Theranos and all of the startups in the healthcare space are, kind of walking around, beating their chest, talking about how cool they are. We're not interested in doing that. Like, we have some videos that we're going to put out, which is basically our customers talking about their hospital and their culture and themselves and how life changed for them. And the software is just a tool that they used for that. With respect to HIPAA and data privacy, we have a full-time chief information security officer, Joseph, and we worked on this for years. Like I think it took us like 10 months before we were able to deploy in a hospital, just working on information security, working on the policies, working on the infrastructure, working on. So it's you gotta kind of have to make a commitment to it at the front end, and as a CEO. And you got to take it seriously. And if you don't take it seriously, like people who work for you don't take it seriously.
No, we found that data security is embedded in the culture of a company. It's not just your product, right? Like you've got to treat your email systems and your whatever communication, however you handle your papers you know, from the morning newspaper on up has to be through this lens.
Yeah, exactly. And, you know, I'm famous for walking around at work, like with the new hires. And, you know, sometimes they'll like, you know, they'll be in this, you know, we used to have this space where we're onboarding new people and they still don't have access to anything, right? So they would get up and they would go make a cup of coffee. By the time they come back, if they've left their computer unlocked, there's basically a big white page open which says, I am in violation of my company's security policy. And, you know, and basically they have to like come and have a conversation on why on the first day at work, they left their computer unlocked. And that's the last time that happens. And it's a part of our orientation, actually. You know,
that's amazing.
we kind of set it up sometimes. I mean, now it's now, I guess it's an open secret. So if you join our company, like, you know, so it's a part of the orientation is we create a situation where people would leave their cell phone on a table or like something like that. And we just, you know, take it and then they go, where's my cell phone? And we're like, oh, where did you leave it last?
that definitely would drive it home. So, you know, nominally, or at least when we started this podcast series 2 years ago, a big part of the focus was on kind of advanced algorithms, artificial intelligence, and sort of where that merges with healthcare. And I actually spend a lot of my time in that space. I know you're rather modest about the technology solution that you've implemented, but tell us a bit more about it and tell us, you know, a bit more about sort of your vision for making smarter use of data going forward, you know, of improving the automation of workflows.
Yeah, I mean, our CTO is, you know, not on a call right now with us. They've done the team has done a fantastic job of building high reliability software. We actually have I would call it an ML algorithm that runs in the background, not to figure out if a person has sepsis or not, but to actually ensure data integrity. Is what is the probability that the patient who you're getting the information through your data stream on is actually the patient that is being referred to by the front end app. So we have something that tests that in real time to make sure that information coming out of the EHR is high fidelity. We, as you know, we used our sepsis platform and started using it for COVID. One of the reasons we were able to do that is while we were working with the CDC on the sepsis product, they looked at us and they said, hey, you know, you realize you can use the same platform for COVID self-assessment. And we said, why, thank you very much. We do think that we can. And so we built a COVID self-assessment system that Harris County, which is the US's third largest healthcare county, deployed. So in the early days, for about 6 or 8 weeks, anyone who needed a test for COVID in Houston, Harris County, so 5.5 million people, right? They had to go to our tool, self-assess, and then get a serial number, and that's how they would get to a testing site based on their zip code. And so we had about 180,000 people that we helped through that. And now we're—
And this was just organic, like you had the algorithms that could be purposed for this.
Yeah, exactly. Yeah. So we were using it for sepsis, and we were talking to the CDC anyway, and we were going to be in a showcase with them on infectious diseases when COVID hit, and the president was coming to the showcase, and they said, hey, we have a COVID showcase too. So I got to talk to the people involved in the COVID showcase, and I started asking questions. And then we kind of connected the dots, and, you know, we did a demo, and they, you know, CDC is a huge organization, right? So we got to talk to people who were working on the other problem. And so the system got deployed in Arkansas first, just north of Little Rock.
Based on the videos from what was it, the Lake of the Ozarks or something, that region's going to have some cases coming soon.
Yes, unfortunately.
Yeah.
Where we're at now with this is, you know, we organically ended up building something that is now useful to bring employees back to work. So we've gone from not just doing inpatient infection surveillance, so to speak, to outpatient reporting. And, you know, if you went to OSHA's website or CDC's website, they're basically custom kind of pointing people towards a solution that does everything we do.
Yeah.
And as of now, we have that first mover advantage. We're the only company in the US that has that end-to-end solution doing this. To be shamelessly plugging my company on your podcast.
That is your job.
But yeah, so we're pretty much daily signing companies up. People with 500 employees, 1,000 employees, people who have a nationwide presence, meat processing plants, accounting companies. We had a defense agency just sign a letter of understanding to potentially
Right.
work with us.
And so these companies will use your tool to help test their employees, track their employees, like make sure their employees can come to work safely.
Exactly. So, as an employer, you want to prove that you've implemented a system that allows your employees to assess for syndromic surveillance, basically, assess for symptoms, and then monitor that person longitudinally. And there's, this FFCRA tax credits that if an employee takes time off because of COVID-related illness, the employer can actually get some tax breaks if they're less than 500 employees. So all of this stuff is like, kind of evolving, and a lot of software companies are playing a catch up. Someone told me on a sales call today that they said one of our resellers brings one of their customers to us and says on the phone call, they haven't even signed an agreement with us yet. And they said, hey, look at these guys, we've gone and looked at 7 or 8 other software companies, including like a large insurer that just put out a software tool for this today. And they said, no, nobody's got their act together like these guys. Nobody's used the product more in the wild than these guys' product has. So yeah, so exciting times for us. Not what I thought I would be doing. We have churches who are customers now. We have meat processing plants, carpet laying companies. It's just
right. Well, I mean, sepsis and hospitals undoubtedly presents an absolutely giant and startup worthy market. Quarter was it 250,000 deaths a year? Was that the number?
Yeah. A quarter million.
So quarter million deaths a year is a great goal, but obviously the nimbleness. I mean, only a startup could be so nimble as to be able to tackle a pandemic in real time like this.
We've stopped calling ourselves a startup recently.
Yeah,
we're calling ourselves, like, I don't know what the term is, but like a growing company.
Yeah, you're an SMB or a small medium-sized business. Sure.
There we go. Yeah. SMB. So mostly because when people start saying things to you like, oh, we've done a full market search and this is the industry's leading platform, plus like the effect we're seeing in hospitals and just having a national presence, I think we graduated from startup phase. Again, like we want to stay nimble. We want to kind of, continue to have all the positives of a startup. But I'm happy we have structure now as a company. I don't miss the lack of structure as the startups usually don't have.
Makes a lot of sense. I wanted to return a little bit to the actual science of or medical science of sepsis. You started by saying that it's maybe more of a syndrome than a disease. It's a lot of different things going wrong. I'm really interested to know whether you envision being able to capture some of the intervention data as well. So to be able to actually not only send an alarm, but to guide the intervention based on real world evidence.
Yeah, you've done your homework really well. Either you've spoken to one of our developers or you've read a lot about this.
I just think about this stuff all the time. This is what we do.
So that's exactly what we're up to now. Is in a huge coincidence, my developer is actually texting me on this side about exactly what you're talking about. We're building exactly that, which is we have an expected response for a person with sepsis, which is namely send blood work, start antibiotics, repeat blood work. The antibiotics change depending upon what's going on with the patient, where the source of the infection is, and so on. That's called antibiotic stewardship. It's a kind of umbrella term for that. And so we're now implementing antibiotic stewardship modules where not only do you treat correctly, you also treat for the right duration. If a person doesn't need antibiotics, you stop it so that you don't get antibiotic resistance. So I sometimes liken this to a car wash. AI sniffer companies is like taking your car to the car wash and they clean your windshield so you can see clearly, and then you leave. What you really need is like the complete, like, we're gonna clean the body of the car, clean the tires, the undercarriage, do all the stuff that nobody else wants to do, right? So that full end-to-end clinical pathway insurance is absolutely what we're up to right now.
Well, it just sounds like a huge opportunity is to not just raise the alarm, but on such a potentially complicated disease or multifaceted, disease where it's not just going in and saying, oh, this patient's in trouble, but if you can actually direct the intervention to the right one. I think a lot about healthcare systems that are really shifting into this value-based care where hopefully we can bring down healthcare costs and do reimbursements based on things that actually make a difference. And so in my mind, the way that, let's just call it smart systems, whether it's a true AI or these kind of intelligent uses of data, they're going to make the biggest impact where they can improve patient outcomes and have this financial, benefit.
Mm-hmm.
But the improving patient outcomes, it doesn't help if you do the wrong thing. So
that's correct. I mean, if you're putting hospitals out of business because you don't understand their business model and you don't understand how they get paid, that's not useful to the patient either. I can think of some ideas off the top of my head that seem superficially to help patients, but they don't really. Like, if it's going to make a short-term fix to the patient's condition, only to find out they get discharged and their insurance is now not going to cover X, Y, or Z pathway that you put them on, that patient's going to get readmitted over and over again. And
so do you see behavior changes among your customers? So you mentioned when you were in the hospital every day, you'd come in and like your first cup of coffee was reading all your patient lists, like who do I have to intervene? Does Sagita have sort of an entry point for, if I'm a nurse starting my shift, is that where I go?
Yeah, good question. So exactly right. So I say this internally to our team very often, that the company is actually not a software company where we are a behavioral modification company, a UI company, and a customer success company that is masquerading as a software company. People run healthcare, like the nurses, the doctors, the pharmacists, the physical therapists, the nursing assistants. These are the people taking care of people in the hospital. So their behavior very much determines outcomes. And we use software to help them get the right habits, track those habits, make sure those habits are well formed and get done every day. Again, more propaganda from my side is, we're publishing some videos online where the CEO of the hospital and the chief nursing officer talk about this. They talk about the culture change, the shift that took place after they implemented software. They were surprised. I was surprised by it. I never thought that, our software would produce a behavioral change. But the one thing that we see consistently is, and I love being in a hospital on go live date, because 60 minutes into the deployment, every hospital has this aha moment where they go, oh, it's like your first iPhone, right? An hour after you got your first iPhone, you're like, what did I do yesterday? Like, I don't understand how. So so I love being there when they have this moment where they're like, wait a second, like, how did we run this yesterday, right? Like, and so that aha moment is usually because there's a behavioral change, that there is something that got made easier for them.
Fantastic. Listen, I've burned enough of your late Friday afternoon on this call, but any closing thoughts? I know we didn't get to talk about any of the fun personal stuff, and we'll include some links in the show notes to some of Sarma's other interviews where he gets to tell crazy stories about his world travels and education in far-flung corners of the world. But any parting thoughts or anything you want people to take away from this conversation more than others?
I greatly appreciate you inviting me and thinking of us to be on this podcast. Although it is a late Friday afternoon, I'm always excited to talk about our mission, and that's what gets me out of bed. I know that's what gets you going to work, is that your company helps people at the end of the day, patients, in your case, patients who have cancer or other malignancies, and in our case, infections and soon to be stroke and heart failure and other disease conditions. Parting shot would be someone, I think it was Dr. Robert Wachter who told me this. He said, I'm sick of these companies in garages that are building software tools for healthcare in silos without talking to their users, without talking to the doctors and the nurses whose lives they're affecting. I just think that if you're listening to this and you're building something, kind of pause, walk into a hospital or a clinic or whoever, or even a patient's house, all right. I just talk to them and run some of your suppositions by them and see if it holds true, because I think that pays off. Like, we've had numerous stories of, people whose lives have been saved by the software, or nurses who are able to go home and hang out with their families and disconnect because they know that they did a good job, because they rely on the software, because they know that they tied off all the loose ends on their patient that day. And I'm a big fan of user-centric design. I'm a big advocate for users. And if you're a software company, like, I implore you,
talk to your customers.
To the people, talk to your customers before you start writing code, or while you're writing code, pretty constantly.
Yeah, no, I think that's great advice. I would throw one out there just from watching you, which is also tackle a problem you're passionate about. I think, you're going to spend 5 or 10 years beating at this problem. You better really want to solve it.
Yep. Absolutely. I have 3 kids. I now have transitioned out of my physician job. I still am credentialed in a hospital. I still try to work a couple of shifts. Just keep in touch and keep the medical part of my brain awake. But yeah, I think if I was not passionate about this, I would have quit probably 5.5 years ago. 6 months into starting the company, because this is hard and it's very gratifying. I think at the end of the day, I think, I'm judging my company's success based on the number of people that we've intervened on. And I have a text message that comes into my cell phone every time we detect a patient who has sepsis. I subscribe to these alerts in real time.
That's amazing. Dr. Sarma Velamuri from Luminare, thank you very much for taking the time to chat with us.
Thank you.
This has been episode 20 of Talking Precision Medicine. Please share it with your colleagues, leave a comment or a review, and stay tuned for the next one. Thanks for joining the conversation.